Well, good afternoon, everybody. I want to welcome you to our second study committee meeting on innovative financial solutions for senior living. And I just want to thank everybody publicly that's given input and offered to come speak and to help with agenda ideas, because I think we all of us that serve seniors or advocate for seniors have a passion for seniors and have a deep appreciation for what they bring to our communities and state and society in general. And we've talked about the burgeoning demographic of seniors that is upon us over the next 20, 30 years. And as a state, we believe it's the responsible thing to do to plan ahead and make sure that we are prepared as we possibly can be to service the needs of seniors and honor them as they age and cannot care for themselves and need housing in appropriate settings. And so as I was reflecting this morning on the way here, scripture came to my mind that I would like to share. And it's in Psalms 92:14, and it says, "When you are of old age, you will still produce much fruit." And I just wanted to throw that out there, just because we're talking about seniors who cannot live as independently as they once could. These are people who used to be in our shoes, used to be the breadwinners of their families. You know, they used to be contributing members of society, and I believe they still can be in their own way. And a lot of times, you know, we see seniors who are alive, but they're not really living in a engaging way in their community. You know, sometimes it's hard to understand, but maybe they're alive to teach us something. And so we can learn from anybody, and I just want to make sure that we just keep that theme in our meeting, and I know we will, but just honor for the seniors in our state, and that's the reason we want to do all we can to make sure their needs are met in a responsible way that brings maximum value to the taxpayers of our state. So with that, just again, thank everybody for what you've contributed so far and what you've done in preparation for today. Mary Lee Boatwright is with us today. She is the Government Relations Director with the Alzheimer's Association, and she's prepared a presentation and is going to be the first to share with us this morning. And while she's coming up, I want to thank my committee members, Tom Kirby, Darlene Taylor, Jesse Petrie, and also want to thank Patrick Love, who's been helping us from the House Fiscal Office. And my assistant's not in here right now, but Latricia Howard's done a lot too to help prepare, and Ledge Council's here with us today. So it's just thanks everybody for coordinating and being a part of it. So Mary Lee. Turn mic on.
Thank you, Chairman LaHood and members of the committee, for allowing me to speak today. And also thank you to Patrick for allowing me to do this handicap accessible location, since I'm recovering from a broken ankle, so thank you. We couldn't have this conversation about innovation in senior living without discussing the growing population of people living with Alzheimer's or another dementia, because they are either currently accessing what we do have available, or there's going to be a growing population who need to access future care settings that we have available here in Georgia. So thank you for letting me speak on this important topic. As Chairman LaHood said, I'm with the Alzheimer's Association, and I want to make sure you know who we are. Our mission is to eliminate Alzheimer's disease through the advancement of research, to provide and enhance care and support for all affected, and to reduce the risk of dementia through the promotion of brain health. We've been serving Georgia since 1982. And we serve the entire state. You can see from this map that we have offices all over the state, and we provide local support groups, community education, and access to local resources. As an association across the country, we've been working with state governments to implement state Alzheimer's plans. And in Georgia, we have the Georgia Alzheimer's and Related Dementia State Plan. We are also working to increase public awareness on early detection and diagnosis, build a dementia-capable workforce, increase access to home and community-based services, and enhance the quality of care in residential care settings. And all of this is to reduce the long-term impact of the disease on state budgets and to improve the lives of those individuals living with dementia and their family caregivers. So I wanted to provide just some data that will sort of set the stage for some of the innovative options that I'm going to share with you that other states have done. But beginning with some data from Georgia. And these numbers, just so you know, where you have the total of 150,000 people living with Alzheimer's in 2019 in Georgia, that is just Alzheimer's, and that's just 65 and over because that's from Medicare data. So the number is larger because you're not including the other types of dementias in that number, as well as those who have younger onset Alzheimer's and other dementias. This data also shows you that in 2019 in Georgia, $1.18 billion of the Medicaid costs are from caring for people with Alzheimer's. And that number is expected to increase 33.5% by 2025 here in Georgia. There's also some very interesting data from the Department of Public Health. Did you have a question?
Representative Kirby has a comment or question.
Sure.
Thank you, Mr. Chair. Is that increase because of the increase in population, or are we seeing an increase in the number of cases per 100
Yes.
or whatever?
It's a
ratio?
combination of both. It's an increase in the aging population, but also an increase in the prevalence.
Okay, thank you.
And there's a link there to the full facts and figures report that has a lot of extensive data. I had to limit to what I could bring to you, but there's a great report there with even more detail than I'm giving today. Also, I included data from the behavioral risk factor surveillance system that we do here in Georgia and across the country. But in 2017, that's done through the Department of Public Health. It showed that 60% of people who reported having memory problems did not talk to their healthcare provider about it. So it just shows you the number of people, and also it speaks to the problem that we have that many people are not diagnosed until they're fairly far into the disease process. And so we work as an association to increase that and hope that we get people diagnosed at the mild cognitive impairment because that helps us improve how to deliver care to them, but also to help the families care for the long-term planning of the disease. So I also am sharing just a few of the national data that I think is important. The overall number of people living with Alzheimer's is 5.8 million, and that number is expected to be to 14 million by 2050. Every 65 seconds, someone in the United States develops the disease. And really the cost of care, the $290 billion in cost to the nation, and I'm going to break that down for you to understand where that comes from in a future slide. But by 2050, these costs could rise to as high as $1.1 trillion. So on a federal level, we often discuss that this could be the disease that breaks Medicare and Medicaid. So you can see, you were asking about the trajectory of the disease, and this does show just how it's going up. In 2019, an estimated 5.8 million Americans are living with the disease, and 5.6 million of them are age 65 and older. So the vast majority of them are that older age, but we do have some that experience younger onset. And again, these numbers are all Alzheimer's only. Alzheimer's is the most common form of dementia, so it's estimated that 70 to 80% of people who have dementia have Alzheimer's, so that's why I'm sharing particularly those stats. So Alzheimer's is one of the most difficult diseases for somebody to be a caregiver of a family member with the disease. And that is because of the burden of caregiving, because of the length of time of caregiving, but also the types of caregiving that somebody needs to provide. And oftentimes that care begins at home. So family caregivers of people with dementia are more likely than caregivers of other older people to provide more extensive and intense assistance. Nearly half of dementia caregivers report providing help with getting in and out of bed, and about 1/3 of family caregivers provide help to their care recipients with getting to and from the toilet, managing incontinence, and feeding. Fewer caregivers of older people report providing help with each of these types of care. These findings suggest the heightened degree of dependency experienced by some people with Alzheimer's and other dementias and the greater burden placed on their caregivers. In 2018, 16.3 million family members and friends provided care for people with Alzheimer's and other dementias. That is, for 2019, valued at nearly $234 billion of unpaid care. Nearly 1/4 of Alzheimer's and dementia caregivers are sandwich generation caregivers, so they're caring for someone with the disease and a child or a grandchild. And that chart there shows you just the average age of a caregiver for somebody with dementia. So I included this slide, but I'm actually going to just skip to the visual of it on the next slide, but I wanted you to have that information. Among Alzheimer's and dementia caregivers who are employed full or part-time, 57% said they had to go in late, leave early, or take off because of other caregiving responsibilities. In addition, 18% had to go from working full-time to part-time, and 16% had to take a leave of absence. 8% turned down a promotion due to the burden of caregiving. And then more than 1 in 6 Alzheimer's and dementia caregivers had to quit work entirely, either to become a caregiver in the first place or because their caregiving duties became too burdensome. Among female caregivers, 17% believe they have been penalized at work because of the need to care for someone with Alzheimer's.
Mary Lee,
Yes.
I just wanted to pause for a minute and
Sure.
comment on some of the information you just shared.
Okay.
I just thought it was worth emphasizing that we're, because of the growing number of seniors and people with Alzheimer's in our state and country, we're seeing a surge in people with the disease, but the caregivers that are impacted. I just want to emphasize that. And you mentioned sandwich caregivers, and for those of you that might not have heard, I just want to make sure that we all grasp that we have adult children who are taking care of young children in their house, raising children and taking care of a parent with dementia or Alzheimer's. And that's a phenomenon that we're going to see more and more of because, people in general didn't have children as young as they used to, and so they've got a parent and children to take care of at the same time. And also, we're seeing more and more of what we call senior orphans, seniors who had no children, or maybe they had 1 or 2 children, but they live out of state, or
Long distance.
maybe they have an occupation, a job that prevents them from being able to be that caregiver. So we have a comment. Who's 20?
That's me.
All right, Jesse, Petrie. Yeah.
Mary Lee, thank you for being here. Great respect for your organization, longtime supporter of the organization through my organizations over many years, and we appreciate you. I wanted to mention, since we took a break here to discuss some of what, you got a lot of data here. So as we're talking about caregivers, it's important to note that, so there's the things that you pointed out on your graph here that are a greater burden on caregivers, because they need assistance with toileting, and the care is so much greater because these individuals are more dependent, as you point out. But I wanted to point out a couple of other things that maybe people don't think about as much. There's other issues. It's so much more difficult on caregivers because of some of the ancillary things that you deal with this population, the things they say, the things they do. We've all, you're talking about caregivers who, and increasingly we're dealing with younger caregivers who maybe oftentimes, I have to say, are not quite as understanding that these people are sick and that they need care. But when they may be grabbing people inappropriately, saying inappropriate things, happens all the time, as someone who works with these populations. And so that makes it so much more difficult. And so I think it's important to speak to your issues that we have to recognize, and I know it's one of your primary initiatives, we really need a specialized caregiver workforce to serve this population. They need to be trained in behaviors. They need to be trained in how to respond to those kind of behaviors. You have to be able to pay people more to serve this population, because it's a much more difficult task physically, but also mentally in many cases. So I just wanted to emphasize that. The other thing I want to emphasize is that when you talk about a greater dependency, you're also talking about a greater burden on providers for risk and liability. And that is absolutely a fundamental in business. The greater the liability, the greater the risk, the more expensive it is to serve people. And that's another thing that people oftentimes miss. So again, just echoing some of the things you were saying here. Thank you.
Yes.
Representative Kirby has a comment.
Question, actually. Thank you, Mr. Chairman. I missed your comment. You said something about females in the workplace, and I missed what you said on that. Could you repeat that?
It was part of one of our facts and figures, and it was a survey among female caregivers. 17% believe they have been penalized at work because of the need to care for someone with Alzheimer's. Oftentimes, there's a much higher percentage of female caregivers, as you probably know.
Thank you.
And I'll second
And
that.
that's on
It's
slide
a lot of
10.
times. It's a lot of times. Most of the time, the adult daughters that become the caregivers or daughter-in-laws.
Right.
We have another comment or question, Miss Representative Darlene Taylor.
Thank you, Mr. Chairman. I know we're talking about Alzheimer's here. I recently have had a constituent that had a disabled child that is now in her 40s, and she has now come down with Alzheimer's. And do you have any kind of arrangements? What happens in a situation like that? The parent has been the caregiver, and now she's not going to be able to do it. And what happens in those circumstances when you have a dependent child? Thank you.
It's a good question. I think it's a challenge that many families face, and I think each solution is going to be dependent upon that family and what finances are available and so forth. But that's really what we're talking about today, is those families that are stuck in that position where they don't have another option. And to your point, Representative Petrie, about a dementia-capable workforce, the training, this disease, early on in the disease process when someone is cognitively impaired, but they can still toilet themselves and bathe, but they need cueing or they need supervision because they may be not safe to stay alone. So the caregiver burden that we talk about, this disease requires caregivers so early in the process, and that burden just gets more burdensome over time as that person declines. So my next slide you'll see is about the duration of caregiving in this disease is just much longer than your average illness. And so that has impacts on people's finances, on people's health. We see that there are many times that we are working with families where the caregiver ends up dying of a heart attack or some other condition prior to the person with Alzheimer's because they have put themselves under so much stress and avoided their own health care and so forth. So the discussion about caregiving could be very lengthy, but I wanted to make sure that you got some significant pieces here that will build on why, I'm presenting the rest. So if it's okay, if there's no further questions, I'll go on. Okay. So as I mentioned, the duration of caregiving with Alzheimer's and other dementias is longer than other diseases comparatively. 38% of caregivers of people with Alzheimer's and other dementias provide care for 1 to 4 years, compared with 23% of other caregivers. And 31% of dementia caregivers provide care for over 5 years, compared with only 23% of people without dementia. And then, of course, that impacts the cost of the disease, both to our state and our nation and to people's private bank accounts. In 2019, the cost of caring for seniors with Alzheimer's and other dementias will total an estimated $290 billion. In addition to these direct costs, the economic value of unpaid care provided by the family and friends of those with Alzheimer's and other dementias was nearly $234 billion. And I'll break that down for you on the next slide. So the cost of Alzheimer's disease in 2019 will be primarily, as you can see, half of which is Medicare expenses, $146 billion, Medicaid, $49 billion, out-of-pocket, $63 billion, and other. So that could be private insurance or other things, but the out-of-pocket is what people are spending themselves. So I want to, as we talk about Medicaid waivers and we get into that, I wanted you to understand a little bit more about the population of Medicaid recipients that has Alzheimer's or another dementia. Over 27% of older individuals with Alzheimer's disease and other dementias who have Medicare also have Medicaid coverage, people known as the dual eligibles. This compares with under 11% of seniors without dementia. Also, I'm going to share the annual number of skilled nursing facility stays per 1,000 seniors. There are 283 skilled nursing facility stays per 1,000 seniors with Alzheimer's and other dementias, compared with just 73 skilled nursing facility stays per 1,000 Medicare beneficiaries without these conditions. This means that those with Alzheimer's and other dementias need skilled nursing facility care at a rate nearly 4 times higher than those without Alzheimer's and dementia. So if we, this slide basically tells you if we can keep people at home longer and in the more appropriate setting longer and out of the costly long-term care settings, then we can reduce that expense per person. And one of the reasons why you see that high number for skilled stays is that there's a lot of data that shows that people with Alzheimer's or dementia often have a comorbid condition. And if you have somebody, if you think about it, who's trying to manage diabetes or a heart condition, and they possibly have an undiagnosed dementia, they might be forgetting to take their meds or eating appropriately for their diabetes. So then that might turn into a skilled care stay or a hospital stay because of that cognitive impairment. So I'm going to talk about some models in other states. So I just wanted to give you an overview, like across the country, what terminology is used, the overview of assisted living facilities. Do you have a question? Do you want me to hold?
Yeah, let's pause just
Sure.
a minute and let Chairman Taylor ask a question.
Sure.
The duration of caregiving, for one thing, are you seeing this increase? Are people starting to stay longer? I know that less than 1 year shows the highest amount, but are you seeing that people are staying in the facilities longer?
That was more about the length of a caregiving, that a caregiver has to provide care, and that it's longer for somebody with dementia. So
Okay.
I don't know that that stat is really related to the length of stays.
That would be one thing I would be interested in, is knowing, are people, for lack of a better word, they're living longer with the dementia? The healthcare all around is
Right.
better, so they are staying alive longer.
Right, managing the
Because
other
of the good
conditions.
quality of care. That being said, I know you've gone to overview, but in looking at the billions, dollars and billions, the
In
the one where
Medicare
it
and
talks about the
Medicaid.
cost of Alzheimer's and Medicare was the largest amount.
Mhm.
Now, is this healthcare, because they don't provide the living expenses?
Right.
So this is just
this
the
is
healthcare.
cost, yes.
And
We're
it
not-
doesn't show private insurance. Would that be other?
That's in the other, yes.
Okay. Is that growing? Can you tell by what your folks are seeing?
Yes. So in that earlier stats
Mm-hmm.
showing the anticipated cost by 2050, that number is growing. And again, that's in part because for the Medicare, it's 65 and over, and that population is growing as well as that population with dementia. So that's why that cost is going to continue to rise. Unless we're all hoping for a cure or a treatment sooner than later, but right now we don't have that.
Okay. And is the, well, I guess the cost of the nursing care, like everything else with inflation, is going up. That was one of the things I've had constituents talk to me about, what they were paying 5 years ago as to what they're paying today. The same thing for the reimbursements, the plans that they had for one parent, for example, paid a higher benefit for a longer period of time, and now they can't get that same type of policy. Are you seeing that?
I can't speak to. And you're talking about healthcare costs versus
No, I'm
the
talking about residency.
inpatients.
I'm talking about residency where they have a nursing home or a
Right.
policy that would pay for it.
Well, in general, I mean, the rate that the nursing homes are paid, and Representative Petrie, you might be able to speak to this too a little bit. I mean,
Their
those
cost of-
haven't gone up significantly. What we're paying. Pam, I know you're here if you want, but the cost of care, as Representative Petrie, is going up
Right,
for
the-
sure.
the
because of
quality and
the
what, again,
acuity.
in rural hospitals, we can't get enough medical care. And I know it has to be affecting them the same way it does hospitals and clinics, just finding the clinicians and the professionals to take
The
care of them.
workforce
Right, the
issues,
workforce,
yeah.
just, it's hard to obtain them. But what I've heard is their policies that they used to pay are increasing in costs now. But I haven't seen it justified
talking
in
about-
what they're paying out. I guess that's where I was going.
And a lot of times what we see is a person with Alzheimer's or related dementia is hospitalized for a comorbidity like congestive heart failure or diabetes complications, for example. And while they're there at the hospital, it's determined that the family cannot take them back home and meet their needs. And so what happens is they get placed in a skilled nursing home at a cost of I think Chairman Petrie is going to speak to that, but I believe it's around $190 a day.
Right.
And so as a state and wanting to bring maximum value to taxpayers, we want to find the most cost-effective setting. In residential settings, cost a whole lot less and can provide care to a lot of these people. And
And the most
so Chairman
appropriate
Petrie is going to speak.
Yeah, you hear me? Yeah, to Chairman Taylor's, that's what it was. To Chairman Taylor's comment, I would just say this. So first of all, 191.26 is the state Medicaid average institutional cost as of today's date. But again, Chairman Taylor, so many individuals are in the private sector. So yeah, you're seeing every year you see, as with everything else in society, you see cost increases, and so like with everything else, providers pass that on, and so the cost of being in an assisted living facility or a memory care or a skilled nursing facility or you name it, on down the line increases. Now in the skilled nursing facilities, about 73% of the population, and there's others here that represent nursing homes, 73% of the population are on Medicaid. So the taxpayers are paying for those folks. But remember, so many people are getting their care privately, and that cost is rising. And so, I think we can expect that to continue. The other issue you're speaking to relates to, it sounds like long-term care insurance. And so long-term care insurance, only 1/4 of 1% of Americans buy long-term care insurance. Almost no one has long-term care insurance. And the policies previously, back in the day before they actuarially got it right, were very generous. And they were great policies. The problem is it failed for the industry because they were too good. And so, today, we're still trying to see that long-term care industry come back, to build back. And I think it's safe to say that they're a little gun shy because they got burned. And so the policies that you see today are pretty mediocre. You can buy good policies, but they're very expensive. And so that, I think, is also what you're speaking to in terms of a constituent issue.
And it's been my observation that the people that have these policies are people who usually are affluent enough to afford to pay their own way, and so they're buying these policies basically to protect their assets. So thank you for those comments, both of you.
Thank you. So before I give some examples of the innovative Medicaid waivers in other states, I wanted to give you a picture of the landscape of assisted living versus long-term care in the U.S. So ALFs are community-based residential care settings that offer room, board, and essential care services. Regulation of ALFs, as I think you all know, is a state rather than a federal responsibility, and all states license at least one category of residential care setting. The most commonly used licensure category, which is used by 44 states, including Georgia, is assisted living. And then all state Medicaid programs require participating ALFs and RCSs to meet state licensure requirements. So the prevalence in the U.S. of assisted living facilities and residential care settings versus nursing homes. There's 28,900 ALFs and 15,600 nursing homes. And that equates to 996,100 beds in ALFs and 1.6 million in nursing homes. So it just shows you that fewer people are served in each of the assisted living settings. So relatively few assisted living facilities or residential care settings are Medicaid certified. 48.3% are Medicaid certified in comparison to 95.2% of nursing homes. Relatively few residential care settings use Medicaid as their payer source, whereas 61.8% in nursing homes use Medicaid as their payer source. So dementia special care units in assisted living facilities. Basically, 14% of Medicaid-certified residential care settings had specialty care compared to 20% of non-Medicaid. Fewer Medicaid-covered residents, 35%, had dementia compared to the other residents, which is 44%. And 20% of Medicaid-covered residents lived in facilities with special care units versus 40% of other residents. So what that means basically is there's a lot more memory care units available in the private pay settings.
And can I stop you right there just a second? And I assume these are national statistics.
Yes, these are national statistics.
Okay.
And I don't have the Georgia stats, and then I have the source on each of those below so that if you wanted to dig deeper, and you're certainly welcome to do that.
Okay. And as a senior care provider, an assisted living owner and operator, I serve the private pay population, and each one of my facilities has a specialty memory care living area. And just one of the reasons we don't provide Medicaid services is because the reimbursement is so low that it doesn't. it would be very difficult for us to ensure the level and standard of care that we like to deliver. And especially for a memory impaired population, the cost of care for someone with Alzheimer's is a lot more than someone without, because it requires more staff, special design of the living area, more safeguards, implementation of technology, wonder prevention, elopement prevention,
Training.
things like that.
Yeah.
And I believe Representative Kirby has something to say.
Thank you, Mr. Chairman. You talked about 44 states having some form of license level for assisted living, but from past years, I know assisted living does not mean assisted living in all the states the same.
Exactly.
How much of a comparison is this? I mean, you got assisted living and residential care, and you're trying to put it all together, but in what those words mean in different states is so different that is this a good set of numbers, or is it just kind of a hodgepodge?
Well, if you want to look at the bigger picture of what assisted living provides, I mean, there is some standards. Definitely the way the care is delivered and some of the terminology of how they, what care they provide is different. But in the larger definition of assisted living, this percentage would fall in that.
Would any of our personal care homes fall into this?
In some states, residential care settings include, yes, a
What
personal
about in
care
Georgia?
home.
With your numbers, would our personal care homes be, license level be in these numbers or not?
Yes.
I would think so, and what Representative Kirby is referring to is in Georgia a few years ago, assisted living became a
License level.
license level
We made a mess.
with a legal definition, and so your average consumer, when they hear the term assisted living, they're thinking about a residential care setting like you've described. Well, in Georgia, that may not be the case. There's personal care homes, and then there's assisted living communities. But I believe you verified that these statistics cover personal care homes in Georgia as well.
Mm-hmm. And these are U.S. too, so it's not specific to Georgia, but. Okay. So just wanted to talk a little bit about Medicaid financing of assisted living facilities, and where in some states what authorities they use to offer financing of assisted living services. So some states use the state plan personal care option. Some use 1915C HCBS waivers, 1115 waivers, 915I state plan option, 1915 community first choice waivers, and also managed care waivers. And the provisions within those waivers that impact access include, what the state sets the program eligibility requirements to, and that its institutionalized level of care criteria, the financial eligibility requirements, the access to services. Some of these waivers can target services to specific beneficiary groups, but cannot cap enrollment or limit to certain geographic areas. And then, other criteria sometimes have to be met, like demonstrating an innovative financing option or service delivery system. I'm going to share a few states, and I'll begin with the caveat that I am certainly not an expert in each of these waivers, but I have included in your PowerPoint, and Representative LaHood has this electronically, a link to each of them with more details, so that if any of them interest you and you want to look further, you can look at those in detail. So some examples include Colorado uses a 1915C HCBS waiver, and these are used to supplement, in each of these states, supplement or pay for room and board in assisted living facilities. Because typical Medicaid program wouldn't cover room and board, and so these waivers allow either a supplement payment to assist for the total cost, or they will pay for the room and board. In Florida, they used the 1950 B and C waivers, as well as state plan personal care. In North Carolina, they use state plan personal care, and then in Washington State, a 1915K waiver. I'm going to tell you a little bit more about North Carolina's waiver because they're close to us. And as I said, there's a link there on your page to read more about it. But in North Carolina, they for SSI beneficiaries, they can qualify for a benefit called special assistance that will pay for room and board expenses up to $1,182 a month at adult care homes, also known as assisted living facilities, but that could be a personal care home here as well. And for people with dementia, you'll note that who live in a specialized care unit, they can receive more money each month. So that's $1,500 versus the $1,182 if they have dementia. And those not on SSI, the income must be lower than $1,229 per month. These figures are from 2018 and must have less than $2,000 in countable assets. In North Carolina, they're able to exclude car, home, and personal effects. Those seeking to live in special care units like memory care must have income less than $1,561 per month. So the financial threshold is a little higher for somebody with dementia. In Florida, they first started this program as a 15 BC waiver, but now that Florida's gone to managed care model of Medicaid, then it's done through their managed care program. But in Florida, they offer assistance with room and board in assisted living and adult family care home is their terminology, which is probably much like our personal care home here. That has no more than 5 residents, and the operator of the home must live in the home. ALFs and AFCHs can be covered by Florida's, as I mentioned, their managed care program. The managed care program will contract with its own providers, and so not every assisted living facility would be covered under every plan that somebody was part of. And then Florida has also a non-Medicaid program called the Optional State Supplementation that allows low-income qualified individuals to pay for their room and board at assisted living facilities. Illinois has one of the newest, I think, very creative model that was actually just authorized in August of this year. In its first round, will serve 1,600 Medicaid members that have dementia. So this was instituted as part of the supportive living program, which we have a similar program, and I apologize, I don't know the terminology, but it's for independent living, really, for people in the DD, developmentally disabled population. But basically, it allows a Medicaid alternative to nursing home care, and it's designed for older persons or persons with physical disabilities. SLP residents have their own apartment. They get to decide on which program services they will receive and determine their own schedule, so it's very person-centered. The service includes meals, housekeeping, laundry, medication management, and assistance with activities of daily living, social and health promotion activities, emergency call systems for fall care, and then well-being checks and routine nursing assessments. The residents in a dementia care setting receive increased oversight by staff and additional nursing assessments, and they also are provided opportunities for more activities in a community setting. The supportive living program began in 1996 and currently has 152 providers with over 12,700 apartments, and 5 of those sites have currently gotten certified as dementia care settings. The SLP operates through a home and community-based services waiver that's been approved by CMS, and this allows Medicaid funds to pay for assisted living services for eligible Medicaid participants who might otherwise live in a nursing home. So just some things to consider in terms of becoming or having dementia-capable Medicaid services. Functional eligibility assessments, which are required to determine somebody's eligibility for a Medicaid waiver program, they need to they measure the need for assistance with activities of daily living, like bathing and dressing, but also for IADLs such as shopping and cooking. And those functional assessments may not always capture the needs and limitations of people with dementia. During assessments, cognitive impairments are often not weighted as strongly as physical impairments, even if they produce virtually the same level of functional difficulty. Functional assessment tools that only focus on the physical capabilities associated with ADLs and IDLs could exclude people with dementia. And what I mean by that is if you're looking just solely at whether or not somebody can do something, and not taking into consideration that it may take 5 or 10 different cueings from the caregiver in order to do those steps, then they may still be able to dress themselves, but not without that cueing. And so one of the recommendations that we at the association have is to ensure that individuals with dementia are able to access needed Medicaid long-term services and supports. Functional eligibility criteria should include and properly weight issues related to cognitive impairment, particularly in regard to prompting, monitoring, and supervision of daily activities. And as I mentioned before, that's kind of speaks to those earlier stages often in dementia where somebody has those functional abilities still, but they may not be safe to make the right choice being on their own at home, either with a stove or driving a car or wandering is a common problem. And then another recommendation or example here is Medicaid waiver programs need to be more dementia capable to meet this growing population and their specific needs. And if we do that, then we are going to ensure that the quality of care is met and it's good, but also will be decreasing costs to the state. Examples of that include making our waivers more dementia capable would include, right now our waivers, if somebody needs it, include a PERS system, which is Personal Emergency Response System. And somebody with dementia who has a fall button on, they may fall but not remember that they were supposed to push the button when they fell. So it really is not an effective tool in many cases. It doesn't mean that they won't, but many of them may not know to do that. But there are some PERS systems that are gyroscope based that actually detect the fall because of the motion of falling to the ground, and there's no need to push a button. Medicaid programs for personal assistance tend to focus on ADLs and IDLs, like the personal support services, but oftentimes you can really assist a caregiver and help keep them home at longer if they have what we call companion care. So, and that also speaks to the dementia training that we need to do and how caregiving for somebody with dementia as a professional caregiver is very different even than other diseases. So that need for that very specific dementia training. And then also ensuring that those who administer that functional eligibility test to determine whether or not they're going to be eligible for this waiver, new waiver, or existing waiver, that they're all consistently trained on dementia and how that impacts that assessment. And I have my sources cited there, and then that's it. So if anybody has any additional questions.
Well, thank you so much. We do have some questions. And I can't thank you enough for preparing your material and presenting it to us, and being so able to answer our questions. So, Chairman Petrie has a question.
Yeah, Mary Lee, I just want to first of all thank you. Great information, very helpful.
Great.
And what I want to tell you is don't go anywhere, because you're going to love the proposal I brought with me today. I have a proposal that I'm going to speak about later that I think is going to be very exciting to you. The other thing I was going to recommend, this is just a recommendation. I think you did a great job showing different states, but sometimes some states I think are better than others to look at in comparison. North Carolina is a great state. Illinois is on the verge of bankruptcy, and we're the most fiscally responsible state in the union. Yeah. And so I think I usually discount anything that's coming out of Illinois and California.
Okay.
Just because I know fiscally how different we are.
We are.
And
Yes,
but I
agree
think
with
that was great information, and I appreciate it.
And I think one of the reasons I brought that one up is because we do have some infrastructure already in place similar to that. So maybe it would be a waiver we could do without too much initial investment, and that was what I was thinking. But I appreciate that comment. And I also included in your packet some fact sheets that really kind of condense all of this down into a sheet that you could more easily reference.
Okay. Chairman Taylor.
About the waivers and how we format it. Looking at the Florida one without reading too much in it, it kind of reminds me, it's very similar to what we have in the developmentally disabled, where we have small group homes. I have concerned how that would work. It sounds good, but when you have potential people wandering and things, that is a concern to me. And the other part of that, we had a lot of problems in my district, particular the care that was being offered wasn't adequate, and you can't get to every little place. That's really became a big problem. We actually had to shut some down because of the caliber of the care that was being given. But again, I think there's got to be some things. I'm anxious to hear what Jesse has to say, because this is something we've got to address. We cannot not, and I again appreciate all the information you've brought to us. Thank you.
You're welcome.
Thank you. And where the facts do clearly point to us as a state needing to take some action and be proactive to stay ahead of this, what could become a crisis. And some would probably say it already is a crisis. I just want to throw out there, too, that the private pay providers that are providing care to people with Alzheimer's, dementia, and just seniors in general who are unable to live independently at home. As a state, I also want to be sure that we're protecting these private pay providers and enabling them to continue providing quality care at affordable rates. If we overregulate private pay providers, it's going to make the costs go up, and fewer people will be able to afford it. And so just wanted to throw that out there while we're talking about all this. So thank you again for your presentation. Very, very informative, very relevant to our discussion. So thank you.
And thank you, Representative LaHood, for having the foresight to know this needed to be part of the conversation. So appreciate that.
Appreciate you. And if you do have time, please hang around, because we might need to refer to you later. Okay. All right, so next I'd like to ask Ruthie Brew, who's the Forsyth County Senior Services Director, to come up, and she's going to talk to us about some of her experiences with seniors. And then when she's done, I think we'll probably take a short break, maybe a 10-minute break, and come back for our last two speakers. So thank you, Ms. Brew, for being with us today.
Thank you. Good afternoon. I'm Ruthie Brew, Director of Senior Services for Forsyth County, located in Cumming. We are in the North Georgia Area Agency on Aging, known as Legacy Link. In my position, I oversee 3 older adult centers. We used to call them senior centers, but now we just say centers, including one primarily funded by nutrition and transportation grants for needier older adults. I have worked in the aging field for over 20 years, have been a caregiver to aging parents and the guardian of a disabled uncle. I propose the issue of affordable housing with services to the Georgia Council on Aging because I see the need firsthand in my professional work, and I've seen it in my personal life as well. Although most older adults prefer to stay in their homes as they grow older, there are circumstances, such as those having dementia, where they simply cannot stay home and they must pursue other arrangements. For those whom are low income, the options are severely limited, and those arrangements are very difficult to make. In my work, I often hear despair in the voices of the older adults who need help with their living situations, but they have neither the support systems to provide it nor the funds to pay for it. Our county senior services department can provide meals, transportation, and an activity program, but that is the extent of what we do. The wait list for government-funded home care services is very long, and there are rarely openings in personal care homes in the North Georgia area. So the truth of the matter is that it is highly unlikely that these individuals coming to us for help will receive help anytime soon, if ever. There are not enough personal care homes that accept Medicaid. I was informed by an area agency on aging ombudsman that in 2000 there were a lot of smaller personal care homes that accepted it, but the reimbursement rate was very low and many eventually went out of business. The current situation in North Georgia is grim. We don't know of any personal care homes in Forsyth County or Dawson County right now that accept it. Hall has a handful that accept the waivers, and the other surrounding counties have maybe 1 or 2 homes. For the North Georgia AAA region, there are 76 individuals right now on the CCSP Medicare waiver program wait list needing services. 18 of those are waiting to get into a personal care home, and 58 are waiting for at-home services. I don't have the figures for those using the Source Medicaid waiver, so there's more than the 76 in North Georgia. The wait is expected to be long, not months, but perhaps years. And when you're elderly, alone, and in poor health, you may not have years to wait. Assisted living communities are springing up all over Forsyth County, but they do not accept Medicaid and are for the more affluent. You may know that we've only had the assisted living level of care for a few years in Georgia. Prior to that, this type of care was licensed as personal care homes. When Georgia created the assisted living level of care, they allowed for that setting to provide a little higher level of care than personal care homes, but not as high as a skilled nursing level. A big difference between personal care homes and assisted living care is size. Assisted living centers must have 25 plus beds, and personal care homes can have as many as they want. Part of this 25 plus bed requirement has to do with Medicaid. In order for a personal care home to be able to accept the Medicaid waiver programs, CCSP and Source, the personal care home cannot have more than 24 beds. Therefore, currently, it is not possible for an assisted living community to accept Medicaid waivers, even if they wanted to, based upon size alone. The Georgia Council on Aging has been studying the housing issue for 2 years now. We have been exploring various financial options for financing both the housing component and the services. The concept is housing plus services, with funding under Medicare and Medicaid. We know that some may exceed the income cap for Medicaid, CCSP, and Source eligibility, and we want to look into the possibility of Medicaid waivers with higher income caps. Medicare will be offering some new options with Medicare Advantage that fund non-medical services for individuals with chronic health conditions, but CMS has not yet finalized those guidelines. Under new federal legislation, Medicare Advantage plans can opt to expand wellness and other supportive services to their enrollees. Senior residential living operators in other states are partnering with care organizations to offer these plans to their residents, providing benefits that are related to long-term services, such as in-home patient support, medical transportation, telehealth services, and adult daycare services. In one example, Ally Align Health of Virginia is partnering with New Jersey-based Juniper Communities to offer these service options in 19 states. We want to include the Department of Community Affairs in our discussions because they can add some service provision requirements to developers who apply for low-income housing tax credits. I would like to share some stories about individuals that come to my centers that have had difficulty finding supportive housing when they could no longer live independently. A 71-year-old female, Donna, with COPD and muscle spasms, who attends our center, is in need of housing with services. Her only child is disabled and living in a group home and cannot help her. Due to Donna's inability to drive and her low income, she has been dependent on her sister for housing and transportation. But her sister died last year and she was forced to move in with her nephew. He has stated that he will have to put her in whatever place will take her Social Security as payment. Her Social Security check is low. She is unable to afford assisted living. There are no openings in personal care homes in our area, and so she will be forced to apply for a Medicaid nursing home. Since she needs minimal medical care, she feels she may not even qualify for nursing home placement, and we don't know where else she could go. An 84-year-old gentleman, Bill, with mild Parkinson's, needed assisted living following a hip fracture. He had been doing well prior, living with his daughter and attending our center, but he could not return to his daughter's home following his stay in rehab because he couldn't do the stairs and there was no bedroom or full bath on the ground floor. His only source of income was Social Security. He received about $1,100 per month. He could not afford assisted living, he could not get into a personal care home, and therefore his daughter had applied for Medicaid for him so that he could move from the rehab section of the nursing facility to a regular long-term care floor. He does not really need nursing care. He simply cannot do stairs, and he needs a place to live. My last story, an 88-year-old woman, Betty, is wheelchair-bound. She is living with her disabled middle-aged daughter and adult granddaughter. Betty and her disabled daughter have only a small Social Security income, and they're receiving Meals on Wheels from our center. Her adult granddaughter is the sole breadwinner. The family was just getting by, and then the breadwinner was hospitalized and lost her job. So the family was in desperate straits and came to our center to get help with food and with bills. Betty cannot be taken care of properly in her home by family members. There is no hope of getting government home care services anytime soon. She does not qualify for personal care home placement, and she cannot afford assisted living. Therefore, due to being unable to walk and having poor family support, it seems there's nowhere for her to go but a Medicaid nursing home. In closing, on behalf of needy older adults, I would like to respectfully request your consideration of exploring options for affordable housing with services, such as an assisted living care center would provide. We would ask that you might consider the possibility of Medicaid being allowed for assisted living. It is well known that placement in an assisted living facility is a fraction of the cost of placement in a skilled nursing facility. It seems to make both economic and humanitarian sense to allow those who do not need nursing care to go elsewhere. We hope to be able to offer our most vulnerable citizens reasonable options, and as a society, find solutions to the elder care crisis. It is a problem that will only grow as the population of older adults increases, and it is important to make plans now. Thank you for your time and attention and concern for older adults.
And thank you, Ms. Brewer, for the testimonials and for sharing some of your experiences. And Chairman Petrie has some comments.
I just want to make a couple of comments because there's no greater advocate for everything you just described than me, just so you'll know that right up front. And again, I would say likewise, Mary Lee, you're going to love one of my proposals I have here today. But I do want to say this because not everyone here on this committee lives in the world that I live in and John lives in. I want to make something clear. So I want to make sure that everyone here is aware that if someone needs home care and if they are eligible, some of the examples you just gave were people who were going to otherwise be in an institution. We do have programs that serve that population. So if someone, the eligibility for a nursing home is de facto evidence that they can be placed on a program and receive those services. So I just want to be very clear about that. So someone who needs home care, who is low income, and who meets a nursing home level of care, absolutely in Georgia today, I want to make sure everyone here in this room knows this, has a route to receive services. The waiting lists for those services today are extremely nominal, almost non-existent compared to I grew up in the world of 1,000 people on a waiting list in every PSA across the state, the 12 PSAs. We'd have 1,000 people on the waiting list everywhere. And so my point is to say this: Georgia, I think, has done a great job of advancing home and community-based services, but we got a long way to go. I'm not suggesting we don't have a long way to go, but it is important that we say we have built a framework to serve people like that. Another thing you said that I think is very important for everyone here to recognize. About a year ago, the Trump administration allowed us, we are now going to have the opportunity to serve people with home care on Medicare Advantage plans, okay? That change came about a year ago. To date, only about 3% of Medicare Advantage plans offer home care, but with over 50% of the Medicare beneficiaries already on a Medicare Advantage plan, we are going to see gradually more home care offered through Medicare Advantage plans. So I want to make sure that we're clear. We're here to talk about the things that we don't have. We also have some good stuff coming on the horizon, folks. That is a great one, and you alluded to that, and it reminded me to say that. So I'm with you 100%. Love what you're saying. Think you're going to like my proposal, but I do want to make sure we recognize that folks like those described, there is a path for them to get services, and the waiting lists are so much better than they used to be. They're not at zero, but they're dramatically unlike they were back in my day. At any rate, thank you.
Do we have any other questions or comments from Ms. Brewer? Thank you again so much.
Thank you.
Appreciate you being with us. All right, it's 11 minutes after 2. I think it's good time for maybe a 10-minute break, and we'll come back at, I want to say 2:25 and get started for the last portion of our meeting. All right, everybody, we're about ready to resume the meeting. I think we're waiting on one more committee member to come in. Here he comes. While he's finishing up in the hallway, I'll go ahead and introduce our next speaker. Ms. Vicki Johnson is the board chair for the Georgia Council on Aging. And she is a fierce advocate for seniors. And I really appreciate what she does for seniors in our state and the voice that she brings for them. And she's going to talk to us today about some ideas on transportation for seniors. And
Committee members. I'm delighted to have the opportunity to talk about transportation because we know that transportation is such an important component for seniors' ability that older adults have to age in place. We know that the population is growing of seniors, and we know that transportation is one of their highest priorities. We're going to be seeing some slides that were prepared for a presentation that I made October 29th to the House Rural Development Council, but were I to have prepared them for today, it would have been the same slides. So I thank the chairman for the opportunity to share this with you, and I'm sorry I don't have handouts, but we will be posting these slides online on your documents for your hearing. Briefly, most of you probably know about the Georgia Council on Aging. We are over 40 years old. We were established by the legislature with the charge to advise state government on issues of importance to older adults. There are 20 of us. We are appointed by the governor, the lieutenant governor, the speaker of the House, and the commissioner of the Department of Human Services. And as committed and enthused as we are about issues for older adults, we know that 20 people do not have a monopoly on good ideas or important ideas about older adults. And so we formed a coalition, which is a grassroots coalition. It's the Coalition of Advocates for Georgia's Elderly. We call it COAGE. COAGE now has, I'm proud to say, over 1,000 members, and that includes organizations as well as individuals. Every aging network organization that most of those who you interact with at the Capitol are members of COAGE now. And so when we speak as a voice as COAGE members, we're speaking on behalf of those members of organizations and individuals. And every year they choose the priority issues that they would like to bring to the legislature in the coming session. And this year, older adult transportation was selected as one of the priority legislative issues. We know that older adults comprise a large segment of Georgia's population. And we know that as they age, women and men will both lose their ability to drive safely. Women by some 7 years and men by 11 years on the average. And so if they cannot safely drive, they still need access to their communities and its resources.
can I ask a clarifying question? Regarding your comment to 7 years for women,
Yes.
11 for males.
Yes,
Are you referring to that's how many years they will live and not be able to drive?
correct.
Okay.
They will outlive their ability to drive safely by an average of 7 or 11 years.
Okay.
In previous years, they may have been able to depend upon nearby family or relatives who could help them with transportation, but now families have changed their patterns of settlement, and they are no longer living in proximity to many of their older adults. And so that's one of the reasons that older adults lack access to transportation. The situation that Mary Lee has described today, it explains another reason that they lack access to transportation. If they have cognitive issues that have caused medical decline, then they cannot drive safely either, regardless of their age. We know that in 2018, the Department of Human Services was charged by the legislature with conducting a study of current and future transportation needs of older adults in each of the 12 AAA regions. This study was undertaken by the Georgia Health Policy Center at Georgia State, and it was distributed in November of 2018 to members of the legislature. And the findings help quantify the dimension of the problem. What the study found is that after you take into consideration the existing programs for human services transportation that are provided by the Department of Human Services, the Department of Community Health through Medicaid, and through GDOT transit services, what remains are 200,000 older adults age 70 plus with unmet transportation needs. That is a lot of seniors who want to continue to live independently, but need access to their communities and its resources. We know also that in 35 counties in Georgia, there is no public transit. So there is no availability. Even in some counties that have public transit, there may be a waiting list to get a paratransit ride, but in 35 counties, there is no public transit. The programs that provide human services transportation now are administered, as I said, by 3 different departments. And that leads to some inefficiencies because they have differing geographic regions that their transportation programs operate in. They have different management staff, and they have different revenue sources and regulations, and they have different providers. And so we think that if these services could be consolidated under one operational unit in the state to administer rural transportation, similar to what has been done already in Atlanta with HB 930 to create the ATL Transit Authority, we think that there would be efficiencies and therefore expansion of services that would result. That's one of the reasons that we are supportive of HB 511, which already passed through the House. And I'm going to catch up here with my slide in a moment. HB 511 is a bill that would reorganize the administration and funding of rural transportation services in Georgia. And it would combine the work that is now done by the 3 separate agencies. HB 511 would create mobility zones within the state. And the current bill, there are 9 mobility zones, and each mobility zone would have a mobility manager whose job it would be to oversee the administration of transportation programs, public transportation programs, and whose job would entail working with the regional government in place that knows the regional and local needs of transportation. And they jointly would work together to develop a transit plan for the region. So it's a program that consolidates at the top, but maintains a bottom-up approach to transit planning. And so those are two reasons why we like HB 511. Some of the barriers that older adults face in transportation are outlined here, and we think that HB 511 could also overcome some of these barriers. I'll just mention a few. If a transit system operates within a county, it usually will not cross a county line with a trip. And we know that medical providers have begun consolidation in Georgia. And while a county may have had a medical center, it's entirely possible that it no longer does, and that medical center is a regional location, but the transit service will not cross the county line. So that's one of the big barriers that older adults face. Another is transit hours. If you have a late afternoon doctor appointment, I don't know about you, but my doctors often don't run on schedule, and so if it's 5 o'clock and your transportation ride ends at 5 o'clock, but your doctor hasn't come into the room yet, then you are stranded, and the AAA directors can be receiving calls on an emergency basis. Help! I need to get home from my doctor appointment. Another problem that older adults face is cost. When we talk about the need for older adult transportation, what we need are transportation trips that are both reliable and affordable. And even though we have added a provision in HB 930 that would allow publicly funded ride-hailing trips like Uber and Lyft to be included in the definition of transit, those trips on a retail basis can be unaffordable, especially when you consider long distances of travel in rural areas. And so what we're hoping for is something similar to what is happening in some places in Georgia, notably in my home county of Forsyth. We would like to see subsidized ride-hailing trips so that it would be a simple process to call a concierge service. You don't need a smartphone. You don't need to know how to use it. You would call a central call-in service like Common Courtesy, which is what Forsyth is going to be using, and the ride would be arranged for you, and some of the cost of the ride would be subsidized using public funding. And so you may pay a cost share of $2 each way for a trip, but that is certainly a lot more affordable than paying 100% of the retail cost of the ride. The other problem that older adults face is what we call quality of life trips. We know that seniors and older adults need, and I should follow Ruthie's dictum and not say seniors anymore. I try and catch myself, but older adults, we know that they have a lot of medical needs, and so they're going to be needing trips for medical services. But there is more to life than medical services, and we know that if you want to continue to live independently in your community, you cannot live in isolation and call that aging in place well. You have to have access to group settings, you have to have access to grocery stores, to drug stores, to friends, to senior centers, and so we call these quality of life trips. And many of the current human service transportation programs limit the trip purpose so that not all of them will cover quality of life trips. We know that isolation can lead to depression and declining health, and we don't want to see that happen when it can be prevented with access to transportation. We know that that older adult riders would have more mobility requirements than younger riders would. And so we need to have transportation providers that can provide adaptive services for wheelchairs and walkers. And there are very few of these. Now, we know that non-emergency medical transportation through Medicaid is available, but there are income restrictions, and even if you qualify for Medicaid, you have to prove that you have no other source of transportation before you would get the medical trip. And then it's only to medical services that are provided by Medicaid. It would not include quality of life trips. We know that the cost of commercial rides, transit services, those can also be unaffordable for low-income older adults. And so we're looking at successful programs for vouchers that would enable an older adult to purchase a highly discounted voucher that would give them access to their public transit network. And then this touches on one of the things we like very much about HB 511 and the consolidation of administration, because we know that there are restrictions embedded within the revenue sources for human service transportation. I'll give you one example. When you're talking about someone who lives in a rural area, they cannot use programs from money from the 5311 federal program, which provides funding for rural transportation, if they are going to a rural medical provider, but they can use it if they're going to an urban. So the trip has to be urban to rural or rural to urban, but it can't be rural to rural. So when the transportation managers try and work a trip solution out for someone, they have to take into consideration the restrictions that come with the funding sources. Well, we can't change many of these restrictions, but what is happening in, for example, coastal AAA is they are able to combine funding sources on a single trip in order to get the older adult where they need to go. And this takes tremendous coordination, and it can be done through a single provider, but you have to have someone who is in place to do the coordination effort. What we're looking for with a change in rural transportation then for Georgians is we're looking for expanded access, and we're looking for reliable and affordable transportation. So we would like to see this consolidated management. We like HB 511 also because it includes some new funding sources for transit. It includes a 50-cent per trip fee on ride-hailing rides throughout the state that would be earmarked for use in transit programs. So this would be a new source of transit funding. It also provides some subsidized rides. We would like to see subsidized rides with taxis or ride-hailing services. We would like to see some financial assistance to volunteer driver programs. There are some very successful volunteer driver programs operating in Georgia. I would reference ITN Lanier in Hall County as one that involves many volunteer drivers who are assisting older adults to meet their transit needs. And then I had mentioned the flexible voucher programs. We would like to suggest that we extend vouchers to friends and to non-family members and to neighbors and to church members who might be able to provide rides, and in exchange they could receive a voucher that would be state funded that would help cover the cost of the mileage and the expense of the gas. And then we also would like to have the state consider expanding its Medicaid non-emergency transportation program eligibility. There are, just as one example, there are care recipients who are using the Medicare program, but they qualify under a Medicaid benefit for qualified Medicare benefit in a QMB program because of their low income status. But QMB recipients are not eligible in Georgia to use the non-emergency medical transportation. And it's purely a state decision. If the state would decide to expand that eligibility, the state would have to fund it, but nevertheless, it would be a way to provide some non-emergency medical transportation to older adults. So we are anxious to see HB 511 come out of the Senate Transportation Committee. We are going to be advocating to voice our support for that bill in that process. We have been working closely with Chairman Kevin Tanner in developing the bill. He has been wonderfully responsive to the needs of older adults and their transportation needs. And we thank the House members for moving the bill out of the House last year on a bipartisan basis. And so we are very excited that there might be some change ahead that would facilitate expanded transportation options for the 200,000+ older adults. Thank you.
Thank you, Ms. Johnson, for the great presentation. You've clearly done your research and brought us, you identified the need very clearly, and I appreciate the ideas too, and I look forward to collaborating with Chairman Tanner to see how we can improve on meeting these transportation needs for seniors and older
great.
adults.
Thank you all. Thank you.
Yeah, you trained me quick on the terminology.
He's easy.
We're all there. 60 and better.
All right, so next and last, but definitely not least, Chairman Petrie, Chairman of the Human Relations and Aging Committee, who I'm a member of, and so is Representative Kirby here. He's lived in the world of providing care to older adults for years and years and years, and so he sees firsthand what families and seniors go through when they're trying to make the decision on what best meets their needs, and when there's not many options out there for them. And so I appreciate the work he does and has done around the state, and appreciate the expertise he brings to this discussion, and thank him for his work on this proposal he's going to bring right now.
All right. Thank you, Mr. Chairman. And I had a handful of copies. I know several of y'all have copies, right? Right, good. So this is not something that I haven't been thinking about for a long time, but it may be a good time to try to advance something like this. So what you have, as has been pointed out today, over and over again, really, if you aggregate all this information, what you have is we do have most of the bases covered for services for our people. Sometimes the funding is not completely there to the degree we'd like it to be, but most of the populations we serve are covered. I mean, we have programs like ICWP for individuals with traumatic brain injuries and otherwise. We have SOURCE, we have community care, we have IDD waivers for individuals with autism and other developmental disabilities. But what we and actually in the world of home care, home care is home care, and you can build a staff of people to serve whatever population you're serving. But what you don't have anywhere in the system at all is memory care units for individuals who are lower income. It doesn't exist in Georgia today. And as I say in here, there's not one Medicaid-eligible assisted living memory care unit. Let me make sure I make something very clear. I'm talking about outside of a skilled nursing facility, okay? Perhaps I didn't say that as accurately as I should. There clearly are memory care units that are Medicaid-eligible in institutions. But outside of that, what we have in this country today, and certainly in Georgia as well, and I've watched it grow I've been doing this for over 30 years, providing care to folks, mostly in the home, in the world of home care, but also in the world of residential services, and now I do a great deal of residential services for IDD populations and aging, really more so with IDD populations. But what I've discovered is as this marketplace has just exploded in the private sector for memory care, much of what you do and know so well, there is nothing like that for really middle-income people and low-income people. So not just people on Medicaid, but individuals that are in the middle. And what happens is when you have the ability to serve, if you have a reimbursement rate for people on Medicaid who need memory care, it really gives you a base to work on, so you can also serve private sector people that may be middle income folks. So most of your memory care units today, and I think I put the state average on here, actually the national average here, you'll see. This is just assisted living in a special unit more broadly, $4,600 per month. That's a national average. So, you can get from various sources, state and national averages. So if you have a higher reimbursement rate, you can serve this population. As we alluded to earlier, you have to pay people more to work in these environments. Moreover, you have to have more staff to work in these environments. You have a greater risk. You have greater liability in these environments. And so today, those individuals that serve Medicaid outside of institutions in residential settings, to my knowledge, no one is serving specifically in a memory care facility. They're certainly serving people with dementias and related Alzheimer's disease, Alzheimer's and related dementias. Folks, that population is everywhere. And as Mary Lee alluded to earlier, many of those people in the earlier stages, what happens is they're served in, typical personal care homes and assisted living facilities. And as they migrate, they then migrate into institutional settings because there isn't anything like a specific memory care unit. And so what this proposal would do is just really simple, keep it simple, no need to rebuild the wheel. You already have an ALS program, have a specific ALS A and ALS Alzheimer's, where you could actually have, through the waiver, CCSP and SOURCE, you could have a home that's licensed to serve assisted living, but specifically memory care unit where you have a higher reimbursement rate. And then what we have to do is see if the market will come to bear. Will the market show up to serve people for that reimbursement rate? I was trying to keep it simple. I put $100 a day in there. I actually believe we were very pleased when Governor Deal was extremely helpful to get the ALS rate up to $50 a day. I believe that is a fair rate for ALS today, and I would not advocate to change that rate. I believe it's fair and reasonable, And but it's not fair and reasonable if you're going to specifically hone in on Alzheimer's. And so a higher reimbursement rate to serve the special population, you could do it in these smaller, whether it's 24 or 20 or 15 or whatever number of beds, you could hone in on Alzheimer's, and you actually would have a reimbursement rate that would allow you to do that, and then you could serve the private sector as well, likely in a facility that's charging less than some of these others that were alluded to today. So that is what I propose. I think that if you look here, the most prominent thing to me is that if you look at, and let me just say this first of all, that there's no bigger fan of the whole long-term care industry than myself, and that includes our skilled nursing facilities. We work together, and indeed, if you're in the residential world for aging, we serve people back and forth with skilled nursing facilities. They're in a skilled facility, they come out, they go back in, they need to be rehabbed. We are a team in long-term care. We've got to have our skilled facilities. However, look at the cost difference. If you were at $100 a day for a memory care unit for Alzheimer's on Medicaid, you would still be $91 a day less than the institutional cost. So bottom line is, folks, as we talk about these demographic challenges we have as a state, people are getting older, there's more people to take care of. Obviously, the first thing that those of us that are up here think about is what's best for people. That's number one. But let's be honest, we have to also think about the fiscal burden on taxpayers, because in the role we're in, let me tell you, folks, all you got to do is get elected to office, and you learn real quick that people care what their taxes are. It is front and center, and I mean, it is powerful. People want to pay taxes, but they want to pay a fair amount of taxes. They don't want to pay more, I'll assure you that. And so we got to think about how do we efficiently serve people going forward. And clearly, you see there the difference between $50 a day and $191 a day, and the difference that would be there between $100 a day and $191 a day. So I think this would be fiscally responsible. It would close a gap that really exists today. It does not exist in this state. And I believe that it would be a real victory for Georgia to have this. I have not spoken to people who are in this space. I am not. The organization that I'm with would not be interested in doing specific memory care units. But I have to believe that if the rate is fair, the private sector will come to serve this population. And so if there's any questions, I'm glad to take them, by the way.
All right, Chairman Taylor.
Thank you. I think this is a great idea, has lots of potential. Could we send it for a fiscal note, just to get an idea? I think that would help us move it and know where we are when we start working on the budget, which will be day one when we're back in session. Thank you.
Yes, ma'am. And what we might want to do is, I think you're right. We should do that and also meet with the governor's office maybe, and we'll see what the committee produces. But at some point, meet with the governor's office, see if we can get others interested, commissioners and otherwise, to make sure that we want to make sure we poke holes in it where it's necessary. There may be a reason not to pursue this, but I think it's worthy of investigation.
Yeah, I do too. And I think the number that's hard to pin down is how much is this going to cost the state if we don't change anything, if we just keep doing things the same way we do right now. I spoke to some people out here in the audience during the break. Does anybody out here have any comment or question? Tom Bauer? Sure, come on up.
I do have a question, Mr. Chairman. I'm Tom Bauer with Leading Age Georgia. What is the age range of an older adult?
I'm going to have to defer to Vicki Johnson on that.
I think it's probably something like Justice Potter Stewart said about pornography. You can't define it, but he knows it when he sees it. So
We know you're in.
I'm in it. Yeah, I know that. Thank you, Mr. Petrie. I know that. I was trying to get at least to be on the cusp of it. Thank you for the opportunity to comment here. And I want to applaud Representative Petrie for thinking outside the box and, excuse me, I'm about to catch a cold, and presenting some more options out there. And I'd like to throw 2 or 3 other things out for the committee to think about at the same time, which I don't think are mutually exclusive to pursuing something like this. One is taking a look at the assisted living community statute, which limits, of course, you have to have 25 beds or more to be one. And also it prohibits using Medicaid funds. And so I think taking a look at that would give us more flexibility and give us more options, and may fit in very well with Representative Petrie's proposal. The other thing you might want to look at some point is Section 1915I, which I thought was a waiver, but it's a state plan, which I think means it doesn't have to necessarily be budget neutral, but it gives a lot of flexibility to target specific populations. And Leading Age had proposed, and it was a little complicated, but it was also the first pass at it, to COAGE about 3 years ago, for the state to consider a waiver for people for home and community-based services who do not meet level of care. And I know you said you didn't want to necessarily identify dementia, Representative Petrie, but one of the prime candidates are people who have early dementia who don't meet the functional categorization to reach level of care. And then finally, I would like to propose that maybe the committee consider how the term use of assisted living is protected now, and letting that out of the box, so to speak. And I think if we did that, it would be good for the consumer, because assisted living, I know when this committee first started working, I offered to Representative LaHood, to Chairman LaHood, to do some research on who did assisted living, who paid for home and community-based services with Medicaid dollars. And as I got into it, it was sort of meaningless, because assisted living really meant something else in the rest of the country than it means here. So I think if we took a look at that, we'd also free up the private sector and have some more flexibility and options. So, and I applaud the proposal, and I think none of these things would be incompatible to consider.
Thank you, Tom, for the comments and the ideas, and the just expanding on Chairman Petrie's proposal. We can get in the weeds real fast if we start, talking about what you can and can't do in certain licensure levels. I will say, though, that for an assisted living community, assisted living communities are restricted to be in at least 25 beds or more. An assisted living community is the only licensure level other than skilled nursing that can admit and retain a non-mobile or non-ambulatory resident. A lot of memory impaired people have mobility limitations, and so I do think that's something to consider, because if someone lives long enough with Alzheimer's, they're going to get to the point where they lose the ability to walk and to self-preserve. So thanks for bringing that up.
Thank you.
Looks like Representative Kirby has a comment.
Mr. Chairman, I just want to reiterate, Tom and I go back, 6-7 years, we've been talking about this word assisted living. It's not that the fact that those are the ones with ambulatory care and the sprinkler systems and everything else that were retroed. It's that term in the general public is all of this stuff, and we got to get it out of the license level, because it just creates confusion to the public. And we just got to call it something else.
That is a fair comment, and I appreciate it. And I think reducing confusion to consumers is a good thing. And anything we can do to help consumers make informed choices for their care and the care of their loved ones is good. Chairman Taylor.
I'm going to ask along that same line, if you would make up a flow chart, even for us, and let's see where these new abilities would plug in. Because I think we can change some of what's existing, but let's look at what's there and what the name of it is, what the requirements are, and then let's see how we can plug your concepts into those. I think there will be a lot of flexibility there. Thank you.
I think
Thank-
that could be
thank-
very helpful too.
Thank you, Mr.
Thank
Chairman.
you, Tom. Does anybody else have any comment to bring to the committee? Kathy Floyd with Georgia Council on Aging, come on up.
Thank you. I just wanted to add to that, it might be worth looking at Florida's 4 levels of care, just to see how that falls out, because they have in their levels of care the ability to age in place, and it is built around dementia care. So I'd be happy to provide the research to provide that information for you.
That would be great if you could email us that model from Florida. Thank you. Anybody else have a comment? Vicki, come on up.
Quick question, and I don't think it's too far in the weeds. So from what I'm hearing from this very interesting and exciting proposal, you're not suggesting that we change the Medicaid waiver eligibility criteria in terms of income?
No, ma'am. No. So if we were to purely, and again, this is just for discussion, so it could morph into other things. But for discussion, what I have here would be the framework that we already have that exists. So we already have those that are indigent and those that are not indigent through community care. We have cost share options. So individuals with incomes up, well above the federal poverty level have access to Medicaid waivers in Georgia. I think we've done a great job of that here. But right now, what's missing, so that same population is what we're talking about. What they're missing is a service like this. So they have access to assisted living. Now, to the comment of the lady in the back who commented earlier, you are correct. The availability of even the regular, to Tom's point, assisted living, even though we don't call them assisted living, to those that are licensed personal care homes available for the ALS service, which is the precise way of saying it, the availability of those are inadequate, okay? That should get better, though, and I want everybody to recognize that. Remember, it was only a year ago when we got this rate right-sized. So if you believe in the free market, as I do, the rate being improved is going to lead to more availability. Remember, it takes a while to build facilities and to create a retrofit facility. So that will come. What's never going to come are locked memory care units for Alzheimer's with the current reimbursement rate. Never going to come today. So great question, and I'm glad because we need to clarify that. This would basically use the same framework and just have all we need is a new level of reimbursement. To say we're going to pay you more, and then what we have to do is just what Ms. Floyd just spoke to. We have to have a way of determining who fits in that category. We have to have a level of care where when they go through their level of care determination, they're going to meet a skilled nursing level of care anyway because they have to be on the waiver, but they're going to have to be a higher level of care where they really do need to be in a memory care unit. But then we would have a way to pay for those people. So they would have access to something that doesn't exist today. And the hope would be that then the market would build these locked memory care units or maybe there's memory care units out there that would begin to serve people for this reimbursement rate.
Thank you.
And I'm cognizant that rate is well lower than the private sector, but with Medicaid, everything we do should always be lower than the private sector and is. And so I thought it was reasonable. But very good point. I hope that's helpful.
I'm Maureen Kelly, and I think you just offered Representative Petrie the clarity of providing an incentive for the few personal care homes who are now offering alternative living services or eligible. But do you know that number? I know in the past it's always been low. I don't know if it's grown or not. And if you don't, that's fine. But thank you for clarification as well.
Yeah, there are a good number of ALS sites, and I don't know off the top of my head, but there's those that are 24 beds and less. are the majority of them, and the providers, and then there are also a little small model as well. So, but what happens is they tend to be, and it goes to a point again that was raised earlier about Forsyth County. So remember, Forsyth County is an affluent county, okay? There's not a lot of poverty in Forsyth County. And so you don't see you tend to see these homes in certain areas, and then you'll have areas where you can't find any. And that's really the challenge, because you really need them everywhere. But they tend to be prevalent in certain areas and almost impossible to find in others. That's my experience.
Mary Lee?
Thank you. Save some time, but I love this proposal, of course, Representative Petrie, and thank you for bringing the idea of a dementia-specific waiver to Georgia. And I think this also offers an opportunity for creating a model of care when we talk about being dementia capable and training healthcare providers in that. And starting from the beginning to create a model that does competency-based training for all the staff and how they operate could actually be a way to show some of the other providers that this model can be done and done well at a lower price, as an example.
Very good.
So thank you.
Thanks for your comment. Anybody else have anything to add? Well, this has been a great discussion today. I appreciate what everybody brought to the committee. Appreciate the participation among the committee members and all the support that's been given to what we're doing here. And that's all the content we had today. A lot to digest. And you'll hear from us soon on the next steps and any proposals that we have. So thank you so much. Travel safe.